Okay. I hope all of you know that I am Murlidhar Pai, Professor of Obstetrics and Gynecology. Currently, I am working as Dean in Sikkim Manipal Institute of Medical Sciences, Sikkim. Ever since I left Manipal in July to come here and take over as Dean, both my PGs in Manipal as well as myself, we are missing each other. Recently, when I went to Manipal, my PGs told that we want some classes from you. So I promised them to take at least 100 classes before before they take the exam. So today only I started taking classes. So I request all of you to please mute yourselves so that we don't disturb each other. And if you have any questions, you can actually put it in the chat box. Otherwise, let us not have any disturbance. It's only 40-minute slot so that we have to quickly finish the class of the day. So without wasting much time, I would like to share the slides straight away. So one of you can tell me that whether you can see the slides. Yeah, I hope you can see the slides. And right. So today I'm going to talk on what is called triple I. Can you all mute yourself, please? Yeah, thank you very much. So today I'm going to talk on a condition called triple I, that is intrauterine infection or inflammation. Earlier, we used to say intrauterine infection means torch infections, but now this is the new terminology that we are using. For a condition which was earlier called chorioamnionitis. Let's look at the different definitions. Chorioamnionitis is a condition which is characterized by acute inflammation of the membranes and chorion of the placenta, typically due to polymicrobial bacterial infection in women whose membranes have ruptured. So basically, it's a clinical condition as per the definition. But then a better terminology was coined, intraamniotic infection. That was because in addition to chorion and fetal membranes, infection often involves the amniotic fluid, fetus, umbilical cord, and placenta. Can I request everybody to mute because it is echoing? You probably are using the speaker to listen to each other. So if you mute only, it is better. Otherwise, my voice is echoing. Okay. So it's not just chorion and fetal membranes that are involved. Other things inside the uterus are also involved. That's why it's called intraamniotic infection. But then there is an entity called histologic chorioamnionitis, which is referred to cases without the typical clinical or microbiological findings associated with acute infection. These cases may be the result of sterile inflammation or use of insensitive microbiologic techniques. So you can make out that there was amnionitis only on histopathological examination, not by microbiological findings or clinical findings. But National Institute of Child Health and Human Development Workshop Expert Panel recommended triple I as a better definition or better terminology wherein both infection as well as inflammation of all the intrauterine contents can be included. To address the heterogeneity of this disorder and is defined by strict diagnostic criteria, I'll talk about that little later. But unfortunately, this terminology of triple I has not been commonly adopted, although the criteria are used. What are the concerns? The concerns are it's a common complication of pregnancy associated with potentially serious adverse maternal, fetal, and neonatal effects. It will affect all the three. Increased long-term risk for cerebral palsy and other neurodevelopmental disabilities. This is the biggest concern. Even if the fetus or the neonate survives, it may develop cerebral palsy and it may have neurodevelopmental abnormalities. That is more distressing situation. What is the pathogenesis? The migration of the cervico-vaginal flora through cervical canal is the most common pathway of the infection. It is nothing but ascending infection. The other one is the hematogenous as a result of maternal bacteremia. But this is not so common. I can say uncommon. Infection from peritoneum via fallopian tubes. You can understand that this is very deviated route and it is very, very rare. Local host factors which can prevent this ascending infection are cervical mucus plug, membranes, and placenta. So they act like barriers. That's why whenever the membranes rupture, this barrier is removed and there will be infection. Now, fetal membranes themselves have some amount of antimicrobial activity. So integrity of the membranes is very, very important. The cells within fetal membranes appear to mediate innate immune responses as well. So it all depends upon the innate capacity to fight the infection as well in the cells of the fetal membranes. Finally, the peroxidase producing lactobacilli in the vagina impair the virulence of organisms. Something like these lactobacilli prevent bacterial vaginosis. So they also prevent the virulence, or they prevent the infection, or at least they impair the virulence of the organisms. That's how the effect of intrauterine infection. What is the microbiology of this? Typically, it is polymicrobial, often involving vaginal or enteric flora. So we have to know this. The organisms are in and around the amniotic cavity. 2/3 of women have at least 2 isolates or specimen of amniotic fluid. So at least 2 will be there. That's why it is called polymicrobial. Then there is transplacental infection. L monocytogenes and Staphylococcus aureus are more common, more likely to be non-polymicrobial, only when it is a transplacental infection. Regardless of gestational age, genital mycoplasms, that is ureaplasma and mycoplasma species, are most common isolate. This can occur at any gestation, early or late gestation. The other pathogens frequently associated with intraamniotic infection include anaerobes, that is Gardnerella vaginalis, Bacteroides suppuratica. And enteric gram-negative bacilli and GBS are also known to cause this intraamniotic infection. Anaerobes appear to be more frequently involved in preterm intraamniotic infection rather than term intraamniotic infection. So that's why we must know these things, which antibiotics to be used when. What is the incidence? Fortunately, it is very low at term, 1 to 4% only. At preterm, it is 40 to 70%, 10 times more. Maybe it is actually the cause of preterm labor through PPROM. So naturally, in PPROM, it is 20 to 25% of the cases definitely have some amount of infection. 7% of term PROM, whereas 40% of those with PROM more than 24 hours will definitely have intraamniotic infection. So PROM per se, if you manage or if you tackle immediately with the prophylactic antibiotics, may prevent infection. But if the PROM is ignored for more than 24 hours, that is the time when there can be ascending infection and there will be intraamniotic infection. So this has to be kept in mind. So we have to take PROM very seriously, and we must take the swab as early as possible and start the appropriate broad spectrum antibiotics while pending the culture sensitivity reports. 20% of women who have more than 8 PV examinations are also more prone for intraamniotic infections. So as PGs, we always tend to do more per vaginal examinations. Sometimes in a medical college setup, more number of PGs would like to know the findings. So more PVs will be done. It is a recipe for intraamniotic infections. This has to be kept in mind. What are the risk factors? So most of the things which we have already discussed come under risk factors. What are they? Prolonged labor, where especially if there has been an early rupture of membranes, then it is definitely a risk factor. Added to that, if there have been multiple pervaginal examinations, it is a sure case for intraamniotic infection. Cervical insufficiency usually leads on to PPROM. That is a risk factor. Meconium stained amniotic fluid. If the baby has passed motion, though we say it is all sterile inside, but there can be infective organisms. Internal fetal or intrauterine contraction monitoring. That will be a case for ascending infection because we are rupturing the membranes. So can you all please mute Swarna, can you please mute it for the sake of others? Swarna Ramanathan, if you are listening to us, please mute your device for the benefit of others. Thank you very much. Presence of genital tract pathogens. So this is definitely a risk factor. Alcohol and tobacco use. Somehow this is not good for anything. So also for the infections. Previous cases of intraamniotic infection, probably their amniotic membranes or their resistance is very low, so they tend to have repeated intraamniotic infections. So these are the risk factors. There is no strong evidence of an increased risk of intraamniotic infection in pregnancies exposed to mechanical methods of cervical ripening versus prostaglandins. This can be a big debate actually. In many centers, they use Foley's catheter as a method of cervical ripening or even induction versus the prostaglandin tablet or the gel. We tried this in Manipal, but we unfortunately fraught with a lot of infection. So we gave up the method actually. Even here, the trials typically excluded women with ruptured membranes. So as long as the membranes are intact, probably the mechanical methods of cervical ripening are okay. But if they rupture the membranes, then obviously there will be a lot of infection, and that can be very, very dangerous. What are the clinical findings in a case of triple I? Fever is present in 100% of the cases. So you can be rest assured that if there is fever, you are dealing with a case of chorioamnionitis along with other clinical findings. What are they? Maternal leukocytosis. We always say up to 15,000 millimeters cube is not abnormal in pregnancy, but anything more than that definitely is abnormal, and there is a focus of infection somewhere. 70 to 90% of the cases will have this. Maternal tachycardia is always a very good sign of fever or infection somewhere in the body. More than 100 is always called tachycardia. 50 to 80% of the cases will have this. Fetal tachycardia. Usually maternal tachycardia is reflected as fetal tachycardia. And all of us know that when the fetal heart rate is more than 160, it's called fetal tachycardia and is present in almost 70%. Easy to remember, as you can see here, look at the second figures. 90%, 100% is fever, 90% is leukocytosis, 80% maternal tachycardia, 70% fetal tachycardia. Uterine tenderness is present in 25% of the cases. This is probably a worse case of intraamniotic infection. Bacteremia, 5 to 10% of the cases will have bacteremia, and GBS in 18%, E. coli is 15%. Purulent or malodorous amniotic fluid. This is a very neglected case of intraamniotic infection, I should say. One should not even wait for this particular sign to emerge to diagnose a case of intraamniotic infections. Then there is something called subclinical IAI, wherein there is no presence of obvious previous clinical findings, but there is subclinical infection, and it may manifest as simply preterm labor without PROM. There can be PPROM, but there is no obvious fever, tachycardia, purulent discharge, and things like that. If you do a computer-age analysis of the fetal heart rate, it may show reduced variability. Otherwise, there is no obvious fetal distress in such cases. So these constitute subclinical III or IAI. What are the maternal sequelae of this? We have understood the fetal sequelae, that is fetal distress, fetal asphyxia, neonatal problems, and later cerebral palsy and other things, but mother also will suffer. There will be dysfunctional labor. Whenever there is infection, the uterine contractions are not good. They are not in the polarity. There will be dysfunctional labor. Usually they land up in Caesarean delivery. There can be uterine atony leading on to postpartum hemorrhage and requiring blood transfusion. There can be localized postpartum infections, something like endometritis, myometritis, or even PID. So that could be a sequelae of a III. It can also be reflected as a wound infection, or it can be septic pelvic thrombophlebitis, which is more dangerous, or even a pelvic abscess. Sepsis, of course, any infection, the end point is sepsis. There is a 12-fold risk of that in cases of intraamniotic infection. What's the differential diagnosis? Whenever there is fever, of course, there is a lot of differential diagnosis, but we must, in pregnancy, rule out abruption, because after all, in abruption also there can be sometimes fever, tense and tend uterus, and the fetal tachycardia, maternal tachycardia, distress, and everything. How do you differentiate? The most important differentiating point is there is some amount of bleeding somehow in abruption and not much of fever. There may be some small metabolic fever, but not a high-grade fever. I'm going to talk about that little later when I talk about criteria. Labor itself can confuse us sometimes with intraamniotic infections, because in labor there can be metabolic fever, especially if the epidural has been used. Maternal tachycardia is not uncommon, because especially whenever there is labor pain, that itself can lead to maternal tachycardia, and maternal tachycardia is reflected as fetal tachycardia. especially if the mother has fever due to any other reasons or some medications. Leukocytosis, as I said, leukocytosis is sometimes misinterpreted by us. Some amount, unless we know that up to 15,000 is okay in pregnancy. Labor and steroids themselves can increase the count of leukocytes. That has to be kept in mind. This may not be due to infection all the time. Other infections, for example, pyelonephritis, influenza, appendicitis, pneumonia, and now COVID-19. These infections can cause maternal as well as fetal tachycardia and leukocytosis and will totally confuse us with intraamniotic infections. So these are the differential diagnoses that has to be kept in mind, and we have to manage a case. What are the diagnostic evaluations? You have to do a complete blood picture, which includes sometimes blood culture, but it is not done routinely. Measurement of CRP is not necessary. Not only that, when we do it, sometimes depending upon the lab, we don't know how to react to that actually. Amniotic fluid can be sent for culture, and that's the gold standard. But it is not again done routinely in many places. It is worthwhile doing, especially if we are dealing with the early case of PROM, that is preterm PROM. Whereas at term PROM or PROM in labor, it may be not worthwhile because the report itself will come after 48 hours. However, in order to prevent postpartum infection, it is still worth it. So it's a good practice to send at least a high cervical swab. If not, there is obvious amniotic fluid. If there is obvious amniotic fluid, please send it for culture sensitivity. Gram staining can be done otherwise. If you feel that the culture will come after 24 to 48 hours, you do a gram staining as a side lab. Presence of bacteria is enough as to say that there is infection. It is 65% sensitive and 99% specific. Glucose can be estimated of amniotic fluid. If it is less than 15 milligram per DL, there is a sensitivity of 85% and specificity of 87%. WBCs in amniotic fluid. I'm not talking about WBCs in the blood. I'm talking about WBCs in the amniotic fluid. More than 30 cells per cubic millimeter has a sensitivity of 64% and specificity of 95%. And finally, leukocyte esterate activity is elevated, and this has got 95% sensitivity and 100% specificity. What are the tests done in research setup? Cytokines can be analyzed, especially interleukins 6, matrix metalloproteinases. A high level of cervicovaginal fluid appears to be predictive of microbial invasion of the amniotic cavity in women with preterm labor and intact membranes. The other thing is proteomic biomarkers in the amniotic fluid and maternal serum are under investigation in an attempt to identify unique proteins diagnostic of IAI. Now I come to the suspense, that is diagnostic criteria for triple I. There are different terminologies and features. When you say isolated maternal fever, it is also called documented fever. Maternal oral temperature more than 39 degrees centigrade or 102.2. Remember this, not a simple fever of 100.4 degree. It is more than 102.2 degree Fahrenheit, or on any one occasion is good enough to call it isolated maternal fever. Please, for the sake of Garima Gupta, Garima Gupta, please mute your audio. Garima Gupta, please mute your audio. The repeat value remains at least 38 degrees, that is 100.4 degrees. Suspected cases of triple I, there is fever without a clear source of pus, any of the following: baseline fetal tachycardia, maternal WBC count more than 15,000, definite purulent fluid from cervical loss. So this is called a case of suspected triple I. What is a confirmed triple I? All of the above, that is fetal tachycardia, maternal increase of WBC, and a frank pus, plus objective lab findings of infections such as positive amniotic fluid gram stain. I already told you earlier that it is the gold standard. So if you send it for culture, that's the best. At least do gram staining. If there is low amniotic fluid glucose, less than 15, I said, anyway, equal to or less than 14. High amniotic fluid WBC, not the blood one, more than 30 cells per cubic millimeter, or a positive amniotic fluid culture, as I said earlier. If these things have not been done, after the delivery, you can send the placenta and membranes for histopathologic evidence of infection or inflammation or both in placenta and membranes, even umbilical cord vessels. So diagnosis for treating a practical diagnosis, what we say a day-to-day clinical diagnosis. ACOG suggests that patients with isolated fever, that is more than 39 degrees or 102.2 degree Fahrenheit, without another clear source, should be managed as having suspected IAI, as they are at high risk for an adverse clinical outcome. So you don't have to wait for culture or the gram staining or amniotic fluid WBC, all these things. Just a fever is good enough to start treating. National Institute of Child Health and Human Development criteria actually de-emphasize use of maternal tachycardia and fundal tenderness for clinical diagnosis. So both are almost trying to say that fever, a high degree fever, is good enough to start our treatment. So what is the treatment? What's the management? IA can only be cured by delivery actually, because you have to remove the source of infection. This is what is the principle of treatment of any infection. You have to remove the source of infection. So delivery is the final answer of the infected products of conception. But till that time, the lack of efficacy of antibiotics alone may be because of amniotic fluid bacteria can form biofilms which are resistant to antibiotic treatment. Prompt induction or augmentation of labor as appropriate is suggested. In fact, cesarean delivery is reserved for standard obstetric indications, not for the infection's sake. Cesarean delivery in women receiving antibiotics, there is no evidence that the duration of labor correlates with the adverse neonatal outcome. Therefore, cesarean delivery is not indicated to shorten the labor duration. In other words, as I said in the previous slide, just because there is amniotic fluid infection or intraamniotic infection, you don't have to jump into cesarean section. Start antibiotics, you can deliver them normally. In fact, if at all you do cesarean section for pure infection's sake, chorioamnionitis sake, it can lead to intraperitoneal infection. So what is suggested is to do an extraperitoneal cesarean delivery. I have seen a couple of them. Caesarean delivery in presence of IAI increases the risk of wound infection and also endomyometritis and venous thrombosis. This has to be kept in mind. Antibiotic therapy, you should start with broad spectrum antibiotics straight away. Ampicillin 2 gram IV for every 6 hours plus gentamicin 5 milligrams per kg. This has been standard right from my undergraduate days. It continues even now. The alternatives being ampicillin, gentamicin, ampicillin, sulbactam, 3 grams every 6 hourly, ceftriaxone 2 grams once a day, cefotitan 2 grams, and if there is any allergy to penicillin groups or cephalosporin groups, vancomycin to be used. Piperazine, tazobactam combination is also used, and in severe cases or resistant cases, meropenem class of drugs are used. Azithromycin 500 milligrams IV single dose is also being used as an alternative. Antibiotic therapy in LSCS for anaerobic coverage should be added into intrapartum regime, that is ampicillin, gentamicin plus metronidazole or clindamycin or tinidazole. So ampicillin gentamicin is standard, but if you suspect anaerobic organisms, add metronidazole or clindamycin or tinidazole. So postpartum also, it's a habit for us to continue with the antibiotics, but optimal duration of antibiotic therapy after delivery has not been determined conclusively. ACOG says additional antibiotic does not require after vaginal delivery, and at least one additional dose is indicated after cesarean delivery. But in India, we routinely give at least for 3 days, sometimes even 5 days. There is no evidence that oral antibiotics are beneficial after discontinuation of parenteral therapy. So other management includes, you have to give acetaminophen for fever, continuous EFM, and for persistent fever or pain, you have to give them a further evaluation of postpartum endometriosis should be ruled out, wound infection, and septic pelvic thrombocytopenia. To summarize what I said so far, the intraamniotic infection or triple I is a polymicrobial infection of membranes and chorion plus intraamniotic contents. Fever, maternal fetal tachycardia, increased WBC bilirubin discharge are the clinical symptoms. Positive AF anti-amniotic fluid bacteria, increased WBC in amniotic fluid and decreased glucose is evidence. Amniotic fluid culture is the gold standard. Delivery is the final cure, but pending that you should start antibiotics. Caesarean is only for obstetric indications and not for anything else. Broad spectrum antibiotics are to be used, ampicillin, gentamicin, and if you suspect anaerobic organisms, metronidazole should be added. Thank you very much. Bye for now. Let's meet tomorrow. I have to take 100 classes, so every day 7:30 I will take class. If there is no class, I'm going to inform all of you. I hope it was useful to you. If there are any comments, if there is anything else, you may actually write to me or either through a WhatsApp message or through an email. Thank you very much. If you have any questions, you can raise the hand or you can ask, otherwise we can call it a class.